Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and PGs, today we shall discuss the fourth case of our interactive workshop on hepatitis B with the theme of translating guidelines into clinical practice. Today we shall see if a chronic hepatitis B patient presents to us with liver cirrhosis, then what to do in such case, when to start antiviral treatment, and which antiviral drug should be started, for how long we should give the antiviral therapy, and when we should stop the antiviral treatment, what we should do with the antiviral therapy if a patient presents with different complications of liver cirrhosis, which is the natural course of these patients. And we shall see how the available guidelines, they help us in the management of such patient. So let's go and see what's the case history for today. Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Dear colleagues, this is the fourth episode of our workshop on the management of hepatitis B with the theme of translating guidelines into everyday clinical practice. And we are discussing case history number 4. Let's start with the case history. It's a case history of a 35-year-old lady, resident of rural KPK. She presented with fatigue and generalized body aches and pains for 2 months. There was no history of abdominal pain, distension, jaundice, or bleeding. She had 4 standard vaginal deliveries at home by thigh. And on examination, she has palmar erythema, spider nevi, and tip of the spleen was palpable. So 35-year-old lady from rural area presenting with fatigue and generalized body aches and pains. On examination, having palmar erythema, spider nevi, and mild splenomegaly. Her investigations revealed hemoglobin 10.7 gram with MCV of 70 femoliter, platelets 108,000, WBC 5,600, INR 1.02, PT 11 seconds. Her albumin was 3.6 grams, that is normal. Urea was 22, again normal. Creatinine 0.64 milligram, normal. Her abdominal ultrasound showed liver measuring a 12 centimeter with coarse echo texture. Spleen size was 14 centimeter. Portal vein diameter 12 millimeter with no ascites. So liver size 12 centimeter with coarse echo texture, spleen 14 centimeter, portal vein diameter 12 millimeter, and no ascites. Her bilirubin was 0.8 milligram, that is normal. ALT was 54, more than normal. AST was 90, and the upper limit was 40, so more than 2 times normal. Alkaline phosphatase was 125, that is normal. Her anti-HDV total, anti-HIV, and anti-HCV was non-reactive. HBV DNA PCR was 1000. HBe antigen was reactive. Anti-HBe was non-reactive. Her Fabro score was 24, that is the fibrosis stage F4, and EPRI was 2.1. She was HBs antigen positive, that hasn't been mentioned here by mistake. So having HBs antigen positive with ALT 54, AST 90, and hepatitis B PCR 1000, she was E antigen positive and E antibody negative. And of course, the FibroScan showing 24 kPa, that is fibrosis stage 4, with EPRI 2.1. So the question is, and you write down your answers, how will you manage this case? Option A, observe with serial ALT every 3 months. Option B, do liver biopsy. Option C, start the patient on treatment with nucleoside analog. Option D, repeat FibroScan after 3 months and see whether the fibrosis is the same or increasing or improving. And E is start treatment with pegylated interferon. So these are the 5 options for you. Either you observe the patient with serial ALT every 3 months, or you do liver biopsy, option B, or you start the patient on treatment with nucleoside analog, option C, or you repeat FibroScan after 3 months, option D, or you start her on pegylated interferon. This is option E. Please write down your option and let's see what's the answer here. It's option C, start treatment with nucleoside analog. Why? These are the EASL guidelines and severity of liver disease, viral load, ALT, and other factors. So if a patient has got cirrhosis, either clinically with having the clinical signs of cirrhosis or on ultrasound, and we knew that in this case, she was having palmar erythema, spider nevi, and splenomegaly. And ultrasound also showed that it was a coarse ecotexture of the liver with splenomegaly. So, and when we did the EPRI, FIB, and FibroScan, the EPRI was high too, and the FibroScan was also suggestive of the liver cirrhosis. So if a patient has got liver cirrhosis, like in this case, just positivity of the PCR any level, this is the indication that you will start the patient on treatment. If she would not have been cirrhotic, if her liver was normal, then of course we would have done the EPRI, Hx-4, and FibroScan to see if the normal liver is having fibrosis or not. If there would have been significant fibrosis, then more than 2000 and LT high would have been the indication for starting treatment. And if there would have been no significant fibrosis, then of course ALT should have been more than 2 times normal, with viral load more than 20,000. And of course, this should have been the indications for starting treatment. If the viral load was high and the ALT was normal, then of course the other factors would have come into play, like more than 30 years age, family stuff, HCC, or extrahepatic manifestation. These are the 2017 EASL guidelines. What I had discussed with you in the cumulative forms of guidelines. And in my lecture previously, as well as in the one of the case histories when we discussed previously, this was the summary slide, and I repeat that when to treat is depending upon the liver status, viral load, and ALT levels. If a liver is cirrhotic, like in this case, then any detectable HBV DNA level, regardless of the ALT, you will start the patient on treatment. Even with the negative PCR, when the patient is a candidate for liver transplant, the antiviral therapy should have been started and should be started. But if and this is the red colored group, when the yellow color group is when the liver is fibrotic, F2, F3, and the viral load is more than 2000, and the ALT is upper limit normal, then of course you start this patient on treatment. But when there is the normal liver, again the ALT, the DNA more than 2000, ALT more than twice, this is the indication for starting this patient treatment. So in cirrhotic, if a patient with chronic hepatitis B presents to you with cirrhosis, the patient is cirrhotic clinically, ultrasound wise, with the EPRI and the FibroScan. You check the PCR, the qualitative PCR, even that is sufficient to start the patient on treatment. Even if you don't do the quantitative PCR, I personally don't do the quantitative PCR in such patients, because to start the treatment, just PCR positivity is enough. And at times when the patient is of liver transplant, then again, I start the patient even with the negative PCR and antiviral treatment with an attempt to prevent the reactivation and then subjecting the patient for the liver transplant. So the patient was started on tenofovir TDF 300 milligram daily. Screening endoscopy showed small esophageal varices, and she was put on biannual HCC surveillance. And these are important. When patient present to you with liver cirrhosis, whatever the cause it may be, you need to screen for the varices, as well as you need to start the patient on biannual HCC surveillance. And of course, when the patient is specifically because of hepatitis C or hepatitis B, HCC surveillance is a must. So the question comes, and the question is for you regarding duration of the treatment. For how long will you give this patient treatment? Till the formation of anti-HBE, because she was HBE antigen positive, or 6 months after the development of anti-HBE, or option C, 1 year after PCR is undetectable for hepatitis B DNA, or option D, 2 years after the normalization of ALT, or option E, lifelong. She was HBE antigen positive chronic hepatitis B with viral load of 1000 and cirrhotic with cirrhotic liver. So for how long will you give this treatment? Till the formation of the anti-HBE, that the HBE antigen becomes negative and anti-HBE becomes positive, or after the HBE antigen seroconversion, you give for another 6 months, or you go for the HBV DNA PCR negativity, and once the PCR becomes negative, 1 year after that. This is option C. Option D is 2 years after the normalization of the ALT, and option E is you give this patient a lifelong antiviral treatment. Option is option E, lifelong antiviral treatment. And this is again the summary slide from my previous talks to you, that when to stop antiviral treatment. If you have started any patient on pegylated interferon, it's a defined duration of antiviral therapy, that is 48 weeks. But if you have started the nucleoside or the oral drugs, the endpoint depends on hepatic and HBE antigen status, how the liver is and what is HBE antigen status. If the liver is cirrhotic, the red strip, it's a lifelong treatment, and lifelong treatment is mandatory in such patient. patient being on the oral drug, so lifelong for cirrhotic liver. If it's a fibrotic liver, the yellow strip, again, this is a lifelong antiviral treatment. The stopping possibility comes when it's a green strip, that is the normal liver, and again it depends upon either the patient is HBe antigen positive or HBe antigen negative. For HBe antigen positive patients with normal liver, so you will stop the antiviral treatment who achieve stable HBe antigen seroconversion and undetectable HBV DNA and complete more than 12 months of consolidation therapy. So then you will stop the antiviral treatment. But if this is HBe antigen negative chronic hepatitis B patients with normal liver and you want to stop the antiviral treatment, so you can stop in those who achieve long-term, that is more than 3 years virological suppression. But provided you can stop in this group, provided the close post drug antiviral treatment monitoring is warranted. If that is important, then you stop. If it's not possible, then you don't stop. So the case history continues. She continued treatment for 1 year. Her HBV DNA turned out to be undetectable. Then she lost to follow-up and discontinued her medications. After 7 years, she presented complaining of low-grade fever and abdominal distension for 1 week. She presented to you. And there was a low-grade fever with abdominal distension. On examination, palmar erythema, hysterexis, and positive shifting dullness. Her investigations: hemoglobin 8.9, MCV 82, platelets 78,000, WBC 4,200, INR 1.9, it was normal initially, sodium 132, albumin again low 2.4 gram, urea 23 milligram, creatinine 1 milligram, and ultrasound abdomen showing liver 12 centimeter, irregular margins and coarse ecotexture, portal vein 14 millimeter, spleen size 16 centimeter, and moderate to severe ascites. So now she presented to you with abdominal distension, and that was because of the ascites, as well as hypoalbuminemia and positive hysterexis. Her bilirubin was 1.9 milligram, ALT 91, AST 102, alkaline phosphatase 129, anti-HDV non-reactive, the PCR now 800, alpha fetoprotein 3.9, and again the anti-HIV, HCV, hepatitis A, IgM, and hepatitis E, IgM, these were non-reactive. Acidic fluid TLC was 150 with high SEG. Child-Pugh score was 11 and MELD score was 22. So with 22 MELD, 11 CTP, 150 cells per cubic millimeter of the acidic fluid, high SEG, 800 units PCR, and bilirubin 1.9, ALT and AST raised, and her PT-INR was 1.9. So, questions is now at this stage, what is the best management option? Option A, start nucleoside or nucleotide in the log. Option B, prepare for liver transplantation and start oral therapy. Number C, the patient has decompensated liver cirrhosis, end of liver care. Or option D, start ciprofloxacin 500 milligram daily as SBP prophylaxis. Or option E, continue with periodic evaluation. So kindly write down your option, what your option is, whether you want to start the patient on antiviral treatment, nucleotide or nucleoside, or if you want to prepare for liver transplantation and starting NA, or end of life care is needed here, or you start the patient on ciprofloxacin 500 milligram daily as SBP prophylaxis, or you continue with periodic evaluation. I hope you have noted down your option. So let's see what's the correct option. It's prepare for liver transplantation and start oral therapy. What dose and what duration? What the guideline says. We are here in a decompensated liver cirrhosis. This is when it's a normal liver, any patient with normal liver, then entecavir or tenofovir, TDF or TAFE, or pegylated interferon. These are the duration, the treatment in a fibrotic liver again. But in a compensated cirrhosis, in the decompensated like this is the entecavir 1 milligram or TDF 300 milligram, and it's a lifelong, and assessments for liver transplant should be done. Antiviral treatment improves liver function and survival. This has been found that when you start a patient on antiviral treatment, it improves liver function and survival. More than 80% transplant-free survival has been reported, and approximately 35% delisted for liver transplantation. But of course, close monitoring for drugs, tolerability, rare side effects like lactic acidosis or kidney dysfunctions are warranted here. So, what should be the drug of choice? Should it be entecavir? Should it be tenofovir TDF? Should it be lamivudine, or should it be tenofovir alafenamide? So write down your option. Let's see what the option is. It's entecavir. Entecavir is the drug of choice over here. We go to the case history. She was started on entecavir and supportive management. Meanwhile, she was counseled for liver transplantation. Donor was not available immediately. So after 6 months of treatment, she became better and her CTP improved to B9 and MELD dropped to 17, which was initially 22. So transplant couldn't be done because of the unavailability of the donor. So she had to be on entecavir and other supportive management, and this is her conditions. The recent investigations showing E antigen negative, E antibody positive, so she has B antigen seroconversion has happened, anti-HDV negative, HIV serology negative, core anti-HBC positive, and anti-HBs negative, and now the PCR is not detected. Her liver transplant was done after donor availability, and HBIG, hepatitis B specific immune globulin, was given in N-hepatic phase. This is the development. So, what is the best prevention approach for prevention of post-transplant hepatitis B virus recurrence? This is the questions. No, she has undergone liver transplant. HBIG has been given. So what is the best approach for prevention of post-transplant hepatitis B virus recurrence? Option A, Continue with periodic evaluation without any prophylaxis. Option B, start Hbig and Na for lifelong. Option C, start Hbig short course plus Na lifelong. Option D, start Na only. So please write down your option. Whether you want to continue with periodic evaluation without any prophylaxis, it should be option A. If you want to start Hbig and Na for lifelong, then option B. If you want to start Hbig is a short course and Na lifelong, option C. Or if you want to start Na only, option D. I hope you have noted down your answer. Let's see what's the answer here. It's a short course of Hbig and lifelong oral drugs. Why? These are the EASL guidelines. All patients on transplant waiting list with HBV-related liver disease should be treated with NA. This is the one concrete guideline. Second, combination of hepatitis B immunoglobulin and a potent high potency or a potent NA is recommended after liver transplantation for the prevention of HBV recurrence. And patients with a low risk of recurrence can discontinue Hbig but need continued monoprophylaxis with a potent NA. This is a case point here, that for prevention of the HBV recurrence, Hbig and oral therapy is important, but there are studies that if it's a high potency NA, patient is on that, then the short course of Hbig is sufficient. HBs antigen negative patients receiving livers from donors with evidence of past HBV infection, that is anti-HBC positive, are at risk of HBV recurrence and should receive antiviral prophylaxis with NA. This is another category of the patients. Lifelong combination therapy should be given to patients who are at a high risk for HBV recurrence, and who are those patients with HBV DNA positive at the time of liver transplantation, or who are HBe antigen positive, or who are having HCC, or who are having HDV or HIV co-infection, hepatitis B and HDV co-infection, or hepatitis B and HIV co-infection, or hepatitis B presenting with HCC, or HBe antigen positive chronic hepatitis B, or hepatitis B patients whose PCR was positive at the time of liver transplant. These are the high-risk patients. I would like to share with you one of the study, and this is the study which appeared recently in 2020, and this is the nucleoside analog monotherapy for prophylaxis in hepatitis B liver transplant patients, and they say it is safe and efficacious. The background of this study is that the combination therapy for Hbig and NA has reduced HBV recurrence post-liver transplant. We know that despite its efficacy, costs for Hbig remain prohibitive. We know it's a very expensive drug, so lifelong Hbig is really a challenge. With high potency NAs, Hbig's use has been questioned. And the authors aim to evaluate the efficacy and safety of Hbig-free regimes in patients transplanted for HBV-related liver disease. So what they wanted to see whether the Hbig-free regimes can be given or not. So what the authors did, they reviewed liver transplant patients at the National University Hospital, Singapore from 2001 to 2015. The patients transplanted for HBV were divided by antiviral treatment received either high or low potency oral drugs, or a combination of Hbig with high potency NAs. So high potency, low potency, and Hbig with high potency NAs. Post-transplant outcomes were reviewed till data censor. Primary outcome was recurrence of HBV viremia post-transplant while secondary outcomes were HbS antigen seroconversion, graft survival, and mortality. So among 58 patients, 51, that is 88%, had persistent HBV viral suppression. Patients on a high potency agent had significantly higher viral suppression compared to those on the low potency agents, and it was 97 versus 72%. This was also seen in patients with very low detectable viral load detectable at transplants. None of the 16 patients with a detectable viral load at transplants and treated with high potency agents developed recurrence. So 42 patients achieved persistent HbS antigen seroclearance. So they concluded that with the use of high potency agents, HBIG may not be necessary in the treatment of patients treated for HBV-related liver disease, even in the presence of detectable viral load at the time of transplant. So they selected the high risk as well, and they found if the patient is given high potency antiviral drug, then probably the HBIG is not needed. And this is their study in the graphic forms. Here, this is the patients with low potency, and this is the patients with HBIG and high potency alone. And what they found that the recurrence was really very, very low here. And this is the post-transplant patients with when the ALT there's a detectable viral load, but the recurrence was very low. And this is another trial which also appeared recently in 2019, long-term outcomes with oral therapy in liver transplant recipients with hepatitis B. The background for this study was that the long-term impact of oral hepatitis B antiviral therapy in liver transplant recipients is currently unexplored at that time. The objective of their study was to evaluate how oral antiviral agents long-term impact long-term renal functions in this population, and what they concluded that tenofovir alafenamide appears to have less of an impact on the renal functions in liver transplant recipients than other antiviral agents. So HBV recurrence after transplant is associated with decreased patient survival and remains an important issue to address for liver transplant recipients on oral therapy. Oral therapy is important, and if it's TAFE, then the renal impact is very, very low. Again, this is the study showing the evaluation of renal and bone safety in post-liver transplant patients with chronic kidney disease receiving tenofovir alafenamide for HBV prophylaxis. And what the authors concluded that TAFE was safe and well tolerated in liver transplant recipients. In liver transplant recipient patients switched from a TDF-containing regime to TAFE at week 24. Viral suppression was maintained. Trend towards improved renal functions and BMD compared with patients who remained on TDF, and BMD bone marrow, the BMD improvements was greatest in TAFE patients with more severe renal dysfunction, and confirmation of these early findings will require at week 48. So, dear colleagues and PGs, the take-home message from today's case history is that treatment of patients with chronic hepatitis B virus and cirrhosis with oral anti-drugs can reduce the risk of hepatic decompensation. This is very much established point. Early and appropriate hepatitis B treatment can improve quality of life and transplant-free survival in decompensated cirrhosis. Post-liver transplant hepatitis B prophylaxis is of paramount importance to prevent disease recurrence. And recent data is encouraging for NO monotherapy in post-liver transplant patients. So, dear colleagues, this was a case history of hepatitis B in cirrhosis and post-liver transplant. When to start treatment, what treatment should be started, for how long should we give it, how to monitor it, what to do when the complications of the liver cirrhosis appears, and when such patients undergo liver transplant. when these patients should undergo liver transplant, and when they undergo liver transplant, what should we do with the antiviral therapy, how to monitor that, how to manage that, and what should we do in prevention of the HBV recurrence and post liver transplant patients. I hope you learned that how the guidelines help us in management of such patients. In the next episode, we shall take another case history, and that's a very, very important case history. Be with me in that, and that will be hepatitis B in a pregnant lady. What to do, what are the possibilities, what to do with the treatment, when to start treatment, when to stop treatment, what treatment, and what are the parameters, all such points we will discuss in that. Till then, I will say goodbye, take care, and please share these case histories with your colleagues, with your PGs, with your youngsters, with the family physicians of your area, because what I have seen that the hepatitis B is very much mismanaged in our society, in our healthcare facilities. And that's the reason I wanted this interactive workshop with you in an attempt to please to ensure that the best possible treatment or best possible protocols are implemented in treating patients with hepatitis B in our community. And I will request you all to please do share your comments, your suggestions in the comments section of this video, as well as to share these videos with other colleagues, so the liver care of hepatitis B patients is improved. And this is the humble attempt of from my side, that whatever we can contribute and we help each other to improve the hepatitis B care, because that is the very much mismanaged scenario in our setup. I'll say goodbye, take care, Khuda Hafiz.